It is just a huge honor for me today to be podcast interviewing on your left, Dr. Sundeep Rawal. On your right, Dr. Bobby Birdie. Let's start with on the left. Dr. Sundeep Rawal is a private practice prosthodontist at Florida Prosthodontics in the Central Florida area. He graduated from the University of Florida College of Dentistry in 2006 and completed his training in prosthodontics at the University of California, San Francisco in 2009, where he was exposed to the most current technology shaping dentistry. He has worked extensively to utilize CAD/CAM technology within the scope of clinical dentistry and enhances patients' restorative treatments. He has lectured across the U.S. as well as international with over 500 engagements over the years and published numerous papers in various dental journals and other publications. Dr. Sundeep Rawal is a past president of the Brevard County Dental Society and of the Florida Prosthodontic Association, as well as an officer for Florida Academy of Cosmetic Dentistry and the Dental Society of Greater Orlando. He is also an officer in the Central District Dental Association and delegate to the Florida Dental Association. He has held numerous positions with the national organizations such as the American College of Prosthodontics. He is a co-founder of the Digital Dental Institute, a leading contemporary education entity with courses all over the world dedicated to innovations and technology in dentistry. He is currently in private practice with 4 office locations in Central Florida, east to the beaches. To his right, that handsome devil is Dr. Bobby Birdie, DMD, MSc, FCDS, FRCD, FACD. The initials keep going and going. He is a periodontist and a prosthodontist at BC Perio Dental Health and Implant Center. He's co-founder of the Digital Institute. He received his dental degree from the University of Saskatchewan and his postgraduate specialty training in both perio and prost from the University of Minnesota. He is a fellow and previous examiner for the Royal College of Dentists of Canada and a diplomat of both the American Board of Perio and the American Board of Prosto. Dr. Bobby Birdie is one of the very few board-certified dual specialists in periodontics and prosthodontics in North America, and the first and only specialist in the world to attain board certifications in these 2 specialties in both the USA and Canada. He currently is acting as an executive member of the board of directors for the Western Society of Periodontology and the Vancouver District Dental Society. Dr. Birdie is the co-founder of the Digital Dentistry Institute, which is a global learning organization for his fellow dentists and one of the largest dental education organizations in North America. He is also founder of the BC Perio Dental Health and Implant Centers in Vancouver, which is one of the largest and most technologically advanced multi-specialty dental centers in Canada. Gentlemen, thank you both so much for coming on the show today to talk to my homies. How are you doing?
Good.
Wonderful.
So,
Thanks
Bobby,
for having us.
do you have some type of what makes someone go out and get board certification in not one but 2 different specialties?
Just begging for it, I guess. That's all it is. But now, you know what? To be honest, I got the opportunity and it presented itself, and I just kind of took it. So it wasn't something I had, poised to spend time on doing. It came on, and I was able to just knock it out along the way. So I'm very lucky and glad it's behind me because it's a lot of school, a lot of work.
Well, Sundeep, I was first turned on to you when you did a Dental Town lecture with the Donis Terzides, on Dental Town. That was an amazing course on implant dentistry. And I wanted to get you guys back, get you on the show and talk about your new Digital Dental Institute. So, Digital Dentistry Institute. So, talk about your journey. What was going on in your life where you guys decided you were going to start the Digital Dentistry Institute? What's it all about? What are you guys doing?
Sure. Well, first off, Howard, thank you very much for having both Bobby and I on the show. We are very excited to be here tonight. And, you said it right. The Digital Dentistry Institute is by far been a journey for us. Really, to summarize how it came about, myself, Bobby, and our other co-partners, Dr. Ron Zokol, Dr. Saj Jivraj, we've been lecturing and being a part of education in dentistry for many, many years now. And over the years, we, came to see that there was a lot of really good, relevant education in certain aspects of dentistry especially when it came to things like the surgical placement of dental implants. How do you do complex surgical procedures? But the reality is dentistry has really changed dramatically in the last 10 years. And most of those innovations have really come in the form of how do we apply technology, this thing we call digital dentistry, throughout all of our all of the ways that we offer therapy to our patients, meaning diagnosis to delivery, right? From treatment planning to definitive restoration. And when we looked at the landscape of where we were educating and some of the focus that we saw in the industry, we realized that there wasn't really a good cohesive message on how to teach other dentists what these new innovations were with technology and how to implement them into your practice and how to treat your patients in ways that were more efficient and faster, more predictable, get better outcomes, make treatment more affordable. There's so much that technology's allowed us to do, and we really didn't have great education cohesively in the marketplace. And so a few years ago, the four of us came together and decided that we were going to embark on this journey. And today, we've grown to, as you mentioned, a global educational institute. And today we do over 50 programs a year in 10 different countries.
Wow, 10 different countries. What are those countries? I assume United States, Canada. What are the
Sure.
other 8?
So we've got United States, Canada, Mexico, the United Kingdom. We are in Malaysia, India, Dubai, the Middle East, Australia, and looking to move into other markets such as China in the near future.
Wow, that is amazing. So who is your core market? I mean, when you just walk out of dental school, are they ready for something like this, or do they need to spend a couple years learning their basic filling, crown? Kind of like if your child started football, the first year or two would just be a block, a tackle, a catch, a pass. When are they ready to go from dental kindergarten school to placing implants and start your curriculum? How long do you think that is?
I think we offer everything for everyone. So when people first come out of school and they're young and they're just starting to get started, we provide a lot of foundational education so they can learn to do something as simple as restoring an implant or treatment planning a simple case and really learning the foundation, the basics well. And then we have to give every avenue when it comes to digital technology, digital dentistry, whether they're going to be iOS scanning or whether they're going to get into anything else, smile design or facially drive treatment plans. We're able to just, a lot of these kids coming out of school are so good at technology already, using their phones and using their tablets and getting on the internet, that if we can provide them with just a certain amount of just leeway and where they can get some of the information, they're going to really take off. And so we provide, foundational information, which is a lot of what we do in North America. And then we go down all the way up to live surgical therapy and even full arch therapy and some of the stuff that's really, really complex. So we have something at the ground where you're able to kind of just start things off, and then we're able to progress. We have things for specialists, some things for general dentists as well, and a lot for just people that really want to get into the field. It allows us to really get you going and make you feel confident.
Yeah, and I want to be very clear on the numbers, because I know a lot of people want to believe a lot of things, but there's this little thing called gravity or numbers or math that bring it on home. Like in the United States, a dental specialist averages $320 in income, whereas a general dentist averages $197. So if you're still in dental school, being a specialist on average earns $100,000 more than being a general dentist. If you own your own practice, you're a general dentist. You net $244. If you're an employee, you net $147. So it's worth $100,000 more to own your own practice than to work for someone else. But here's where these guys come in. Oral and maxillofacial surgeons are the highest. They average $448,000 a year. Periodontists at number 2 at $330, endo number 3, $307, pediatric next at $304, ortho $289, pros $219. So what that inversely correlates to is blood. Dentistry is all hands-on surgery. And when somebody comes out of school, $284,000 in debt, and they say, well, I don't really like blood. I just want to do bleaching, bonding, and veneers. I'm like, dude, you're a doctor. Who signs up to be a doctor? I mean, did you mean to become an electrical engineer? How did you end up being a doctor? So these guys are teaching you how to place implants. That's where all the big money is. It's far more lucrative to pull a tooth and place an implant than all the bleaching, bonding, veneers. Like everybody right now is talking about Smiles Direct Club. Smiles Direct Club isn't going to pull your tooth and place an implant. They're in the non-bleeding category. So when these kids walk into your course for Core 1, implant treatment planning and restorations, what letter grade would you give their dental schools? I mean, when they show up to you at a dental kindergarten class, are you like, man, they did a good job, they know all the didactic basics, or is this like talking to Pluto?
Yeah, I would say it's somewhere in between. I'm not going to throw all the schools under the bus, but they got to learn a lot when they first come in, and they hear a lot of things, and they may Google things and look on YouTube and whatever have you, but they have a lot of foundation, need to learn simple basics. And the reason why also is because a lot of times as dentists, we try to make whatever we learn about a tooth or teeth and try to apply that to implants, and implants are not teeth, the same rules don't apply. But we try to do that as dentists, try to make it simple for ourselves. But that's one of the biggest, I think, dogmas we need to break when we first start to teach it, right, son?
Yeah, and Bobby's absolutely right. The level of knowledge and skill that we experience when participants come into our courses is somewhat variable, to say the least. Look, the reality is in dental education today, there is so much that's changed in the last 15, 20 years in dentistry that being able to comprehensively teach it all in 4 years, the same amount of time frame that we spent learning, what we learned 20 years ago, but now we've got 40% more information and 40% more science behind that. It's tough to do. And then when you start layering in things like technology and how do we actually use some of the most state-of-the-art innovations that we have to actually offer those therapies to our patients, it can be quite challenging for anyone to learn all of that in a comprehensive dental education curriculum in school. And so, that's the impetus and why education in dentistry as an industry is tremendous across the board. And it's a necessity, really. And so, especially, Howard, when you bring it back to the numbers, like you say, and really talking about the fact and the reality of the economic drivers of dentistry today, yes, blood is so important, and being surgical and it has a really high value dollar return in a practice today. But also on top of that is the use of the technology, because, where we may gain, economic incentives to add additional procedures into our practice, we can also gain economic incentivization by taking our existing procedures and implementing technology to them.
Now, why should they learn how to place implants when on your website you have Yomi, the robot-assisted dental implant surgery is here? Can't I just stay home and drink beer in my jacuzzi and have my little Yomi robot assistant place all the implants?
So that's a very pertinent question, Howard. And in the fine print, it says robot-assisted dental surgery. So this is for me, look, I think technology is the one defining factor of our generation in dentistry today. What implant dentistry was 25 years ago in dentistry and the renaissance that it brought to our profession, I think we're in the midst of the same renaissance with technology. And so embracing technology, which includes robotics, though it's robot assisted. We can't be drinking the beer in the hot tub. We still have to put our hand on the handpiece. But the reality is, embracing technology, embracing better ways to offer therapeutic outcomes for our patients. That's what, Bobby and I believe in our private practices. That's what we espouse through DDI. And that's, making sure that we've got the best tools and technology to affect real change in our patients' lives, including robotics, which, will one day potentially be one of the most predominant mechanisms we have to do surgical procedures in dentistry.
Okay, I want you to put your dad hat on first, because
Sure.
I've been in a lot of dental schools for a lot of years. There's two in my backyard, and when they come out of school, I mean, they're honest with you. You know, you can be at a bar with them, having a beer, watching a ball game, and they'll say, "Look, you know," I mean, they just graduated, 3 months ago. And they say, "Look, man, I am not doing any more molar endo. I've tried that twice. Both of them beat the crap out of me, and I'm not placing implants." I mean, so what do you say when they're 25? They've only seen this cobra twice, and it bit them both times, and they immediately want to repel back into Invisalign, bleaching, bonding, and silver diamine fluoride, and they need to put their big boy pants on and go get back on that horse that bucked them off. And what do you say to a kid if they're just kind of scared and say, I don't know if I could place an implant? Because it's easy when you're old like me and you say, look, it's actually easier to pull a wisdom tooth. I mean, it's harder to pull a wisdom tooth than it is to place an implant on a first molar or a maxillary bicuspid. So what do you say to them when they're scared?
I think that the biggest thing I find for people like that, doesn't matter if they're new or if they've been in practice for many years, and they just, I don't do extractions. I don't like doing things because they get stressed out about it. A lot of times it has to do with the fact that they either were taught a certain way, and then certain constructs of what they were taught didn't work for them, or they don't have the knowledge base or the understanding they wish they did about something to really be able to do it well. So, when we talk to those people, we have them come take Core 1. That's why Core 1 is Core 1. It's restorative and treatment planning, where they learn why they're doing what they're doing, and they realize the implant's just, if you're building a house, just a concrete. You're just putting in something that's going to help the foundation of what you got to do. So by providing them with more of the knowledge base and for them to be understanding, and the thing too is our courses are all designed with their hands-on every day of every session. They're really going to get their fingers right and really be able to kind of put this to paper when they're done. That's a big deal.
So on your core classes, so when you go core modules, core 1, 2, 3, 4, 5, those are one day course. What?
They're 3-day courses. 3-day courses.
They're 3-day courses. So if I look at your next one, September 13th, so that date showing up September 13th is the first day, but it's actually
3 days.
13, 14, 15?
15. Yes, that's correct.
Okay, those are 3-day modules.
Yeah.
So do you have to, do you make them take them in order? Like you take module 1 before module 2, before module 3, or do they go in orders like that?
Yeah, so that's a great question, Howard. The way we designed the curriculum was twofold. One, we wanted it to be something that could ultimately be a continuum for that specific practitioner you were just talking about, the young, eager, just got out of dental school. I don't really know anything. I'm a little timid. I'm a little shy to actually embrace newer concepts or things like surgery because I just don't have a comfort level. Well, we have a continuum that you can start with, starting with something like Core 1, working your way through all the core programming, then layering in things like our digital track, ultimately graduating to live patient programs where you're actually operating on live patients, to master classes, so that over time you can build on the complexity of your education as your skill set goes up. We built it so it could be that continuum, but at the same time, we also built it so that each individual program is a standalone program. So if I am let's say an oral surgeon or a periodontist who's been placing implants for a lot of years, but I'm not really comfortable with full arch therapy, I could jump right into a full arch program, whether it's a didactic and hands-on based course or a live patient course, and get what I need out of that particular subject matter without missing out on something because I didn't start at the very beginning. So we kind of designed the curriculum to do both of those things.
A lot, depending on what country you are, you see things differently. But in the United States, so much implant continuing education is tied by the manufacturer. So a lot of dentists are emailing me, howard@dentaltown.com, or they put notes in the comment section on YouTube where they're saying, in my state or where I live, I need to pick the implant system first because all the CE is sponsored by the deal. So are you guys implant agnostic? Do you recommend a certain implant system? Where are you at with that?
So, Howard, our primary focus 100% is on education. We believe that the most important thing that we can do is educate our participants on concepts, on science, on techniques and protocols, utilizing, technology to really offer the ability to treat their patients better. In that conversation, obviously, there are different manufacturers, different brands that, whether it's implants, whether it's intraoral scanners, whether it's CBCTs, there's plenty of different products in the marketplace that you can use to offer those therapies. Our goal is to educate. Our goal is to make sure that our participants understand the why of what we're doing and how to apply it, more importantly, to everyday private practice, so that they can take the education that they from our courses and actually apply it on Monday morning. But we certainly recognize that, there are products in the industry and their brands, especially when it comes to implants, that, allow our clinicians to be able to do certain things in ways that may be better than other companies. So we definitely have key strategic partners that we work with when we're educating, and we certainly highlight, the benefits of why we choose the partners we choose. But, our number one focus is to educate and really to make our participants become better dentists in their daily practices. I don't know, Bobby, you want to add to that?
Howard, I'll say that whenever we're using or promoting anybody in our courses, it's not because we're promoting them for hearsay. We're promoting them because we use the product, and we have used those products for many, many years. So whether it's an iOS scanner, whether it's a 3D printer, whether it's a dental implant, whether if it's a prosthetic material, all of it has to do with the fact that we use the product. And now the beauty of our faculty conglomeration is that we've got 20 plus speakers all using different systems, different modalities, different everything throughout the world. And so we do have the ability to compare and contrast whatever we're doing. And when anyone comes to the courses, we're able to help them out with whatever system or whatever we're going about. But we do try to keep our message pretty clear and concise and parallel throughout all of our courses.
On the 3-dimensional printer, do you know how to make it 4-dimensional?
I think that's virtual reality. I love that. That would be awesome.
All you gotta do is just give it a little time.
Yeah.
So you have 20 different lectures. You all don't agree on everything, but if you had to give them, I'm going to hold your feet to the fire. If you had to give them one implant company to start with, give them one name, give them one brand name.
I would use Noble Biocare.
No BioCare? Yeah. And why? You're a double specialist. You're a periodontist and a prosthodontist. It's very, to me, I think it's very interesting where all the specialists I know pretty much are into Noble Biocare and ICAT. Yeah. I mean, if they got a CBCT, it's always an ICAT. Why are they always? First of all, do you guys notice that too?
I'll tell you that the reason why an ICAT is being classically utilized in most surgical offices, surgical specialists, is because of the field of view that was offered when they first came out with the machine. And it's because they were in a lot of the schools when they're taught. I have an ICAT Flex and I love it. It's a great machine. The radiation dose at this point is the lowest pretty much in the world in the smallest amount of time. And it's a great amount of, the information you gain is amazing.
So you you use ICAT when you were in perio prost school. 100%. And how about you?
We had a few different systems when I was doing my prosthodontic residency.
But was ICAT one of them?
ICAT was one of them. Today, working with various different companies throughout my 4 offices. We have CAVO scanners, CBCT scanners in the practice. We have a Sirona scanner in our practice. We've tried to embrace multiple technologies. But, I think you're absolutely right that from a specialist standpoint, they have gravitated to certain products, especially when it comes to dental implants and things like Noble Biocare. A lot of that is steeped in the history of specialists trying to use products and services that have been, I think, tried and true, tested with evidence-based dentistry with the longest historical run, with, a proven track record. And, when we look at that, and, when you say hold your feet to a fire and what would you pick for an implant system across the board, Bobby and I both agree that, we both in our private practices use Noble Biocare because it is one of the longest standing implant companies in the world, if not the longest. It is 100% has some of the most science out there compared to some of the other newer implant companies. And it's one that we feel comfortable not just educating on, but more importantly, we feel comfortable putting that in our patient's mouth.
Plus, they're going to be around in 10 or 20 years. You know what I mean? Like, we're talking about a large company that's been the foundation of implant dentistry for a very long time. And I think that they're going to be around. And that's a big deal with all, like, a lot of new companies. And I always compare it to like the automotive industry, where you have newer, smaller companies coming up, and then they come and they leave, and they come and they leave, and you can't find parts and whatever have you. I'd rather be working with a company that I know and I can feel fairly confident that they're going to be around for a long time.
So, Sundeep, you went to University of California, San Francisco, right?
Yes, I did.
Dr. Brandmark's son is an orthopedic surgeon in that town. Did you run into him?
I did not. I did not know that he was an orthopedic surgeon in that.
Just like his dad. His dad was an orthopedic surgeon, but when they started testing, titanium, they weren't going to test artificial hips on mice, so they just stuck pencils in mandibles. But his son is an orthopedic surgeon, just like his dad, in San Fran. But I can remember when his dad came to the United States, only oral surgeons were allowed to learn. And
Absolutely.
then after a while, he lowered the bar and let the periodontist walk in there.
But there was a rationale for that, Howard, because at the time with PI, I mean, the thought process was that an implant had to be placed in a completely sterile environment, and some of the sterile protocols that we even have to this day for implant placement. And so when he first brought implantology to North America, and he said, well, this needs to be placed in a sterile environment. Who had access to sterile environments at the time, right?
Well, I completely agree with this protocol, but where I was going with this question is, when you look at the, I always tell dentists, if there's any dental company publicly traded, you got to buy one share of stock in it, so that by law they have to mail you their 10Qs, their quarterly reports, their 10K annual reports. But you just get so educated on this industry, and when you're reading the shares of like Straumann, which is the largest implant company in the world because they've mergers and acquisitions. They bought Neodent in Brazil. They have all these companies, but one of the reasons their stock is so well is because they show that in countries like Korea and Germany, 3 out of 4 general dentists placed an implant last month. But then when you go to the big market of the United States, it's not near that. And so there's so much upgrowth in that. So you're in Canada, you're in Florida, I'm in Arizona. That's kind of really pretty much the same country. Why do you think general dentists in Korea, South Korea, and Germany, and for Spain, 3 out of 4 general dentists placed an implant last month, and we're not anywhere near that in the United States and Canada? And do you think that's going to be changing? Do you think in 10 to 20 years we'll be more Korean and German than we are today?
I mean, I'll answer for the States, and that I'll let Bobby kind of touch on Canada, since he's our resident expert up there. I think a lot of that has to do, and especially with the fact that we educate around the world, and so routinely our team, including myself and Bobby, we're flying constantly around educating and seeing what's out there in the different countries and their different marketplaces. There's 2 factors there. I think one factor is the paradigm of what is traditionally within the scope of a general practitioner in other countries. If you go to a market such as Korea, you go to a market such as India, for that matter, much more advanced or complex procedures are done by the general practitioner compared to what's done in this country. And therefore, they're much more readily, they're more ready to adopt things like implantology into their practice. There's much more of a single center mentality when it comes to offering care in those countries. And therefore, the general practitioner needs to be trained to do not just implantology, but quite a bit of other surgical specialty procedures that otherwise would not be done in this country. So I think there's that paradigm of what the scope of a generalist does in those countries that affects that. And I think the other part of that, compared to the U.S. specifically, is our model of payment and reimbursement compared to insurance-based healthcare systems. When you look at this, the dentistry, the dental market in the U.S., especially when it comes to procedures like implantology, we are very much in a discretionary dollar environment, right? It's elective procedures. It is discretionary dollars where, patients pay for those procedures out of elective monies, which means, they don't readily accept treatment where they may in a country that has socialized dentistry, where, their dentistry is covered through their overall insurance plan, and therefore they're more readily to accept it. And therefore the number of implants, per generalist that get done is much higher. I mean, I think that's definitely a striking issue when it comes to what your comparison is in the States. I don't know, Bobby, what do you think about Canada?
Some of the things that I know is that per capita, the number of implants that are placed, the number of general dentists that are placing implants in Canada is higher than the U.S. in terms of percentage of per capita. And I think some of it has to do with the readily available specialists in certain markets and having the ability to work with them. When we go overseas and we go to other markets, whether it's Korea, Germany, other parts of Europe, the single care provider type of therapy where one clinician is doing more and more is not only becoming more prevalent, it's also becoming more of a cultural thing, especially in Asia. It's almost, all the dentists are doing everything, and they only refer if there's an absolute problem or an issue. And I think in both the U.S. and Canada, we're going to see more of that, where my office is very much a one-stop shop, very much a multi-specialty, our own lab and everything. And we are a one-stop place where we can do everything. And I think that is going to be more and more of the future of just dentistry in this type of field going forward, where you walk in somewhere and they can provide everything for you, whether it's one practitioner doing it all or whether it's a team. I think we're going to see that more and more throughout North America, just because of that reason. Now, in terms of the insurance side of things, Canada is very different than the U.S. because, yes, we have their insurance, but people pay us as dentists first and get reimbursed by their insurance afterwards. So it is discretionary. It is private. Whereas if you're in a country such as, whether it's Switzerland or other countries where they have socialized dentistry, then you're right. It could be quite different depending on the market. So I do think we will become more like that over the next 20 years. I do think so.
Much more like what? Like Switzerland?
Much more like South Korea. I mean, we'll see more and more practitioners placing implants. The number of implants placed by general dentists was greater than half of the ones in North America last year. And so most of the general dentists didn't place more than 20 implants in general, but there's just a larger number of them. And because of that reason, general dentists are able to do more, and that's fantastic if they're able to provide services to their patients.
I've always thought it was bizarre that the continuing education courses never match supply and demand. Like if you go to all the major meetings, they always bring in some heavy hitter to talk about an all-on-4, whereas everybody in the audience does all-on-nones. And
Exactly.
I always want to interrupt and say, okay, raise your hand if you've ever done an all-on-4. And nobody raises their hand. And it's like, okay, where's the course on the all-on-nones? Because everybody in this room did a denture this year. So, is it the same in implantology where, the majority of the implants, take crowns, 96% of crowns are placed one at a time. Every time I look at implant data, it's the same thing. They're placed one at a time. But all the lectures are all-on-4. It's always somebody doing some supermodel in a swimsuit edition, and she needs, an implant on her front tooth or something like that. But is it when I sit with my insurance friends and there's 32 teeth, all the dentistry's done on 4 6-year molars. The first molar is most likely to have an MOD filling, a crown, extracted, an implant, a root canal. So the 4 big monster spikes are the first 6-year molars. And in fact, when that 6-year tooth comes in, I mean, why would you do a sealant on that tooth? That tooth's most likely to explode and kill the person sitting next to them. I would want to clean out the pits and fissures and do a preventative resin restoration. I mean, whenever I see a 6-year molar pop through, I mean, that's the class clown. That's the kid in the mouth who's going to get in all the trouble, not the one in front of him, behind him. That's the troublemaker. So is a lot of your curriculum teaching real world first molar, one implant dentistry on replacing that one 6-year molar?
Absolutely. I would say most of the core programs, core 1 through 4, are to help address just that normal dent. Most implant cases are 1 to 3 implants per case. And that's where core 1 through 4 sits. That's what it's about. Even core 5, that's what it's about. Yes, there'll be anterior implant restorations and provisional restorations and type of surgeries that involve that as well. But core 1 through 5 is purely to address what 90% of, or I would say 80% of implant dentistry truthfully is, which is 1 to 3 implants.
Yep. And more to that point, it's also very important to us that everything we teach in those cores is very practical and can be applied on Monday morning to your everyday dentistry. And you got to remember, Howard, that, when we started this company, it was started by 4 private practitioners, everyday dentists who get into the trenches on Monday morning at 8 a.m. And so it was really important to us that all the concepts that we teach are pertinent to that average private practice. The guy that wants to place the one implant in that maxillary bicuspid wants to learn how to place it well, wants to learn how to place it efficiently, wants to learn how to place it easily. That's where we gear 90% of our curriculum to, those concepts.
And when, the patients, is when you're young, when you're a 25-year-old dentist, you can get talked into a lot of trouble by an older patient talking hey, come here, walk off this cliff for me. And you do it when you don't do it when you're old. You do it when you're young. And they want that tooth pulled and the implant placed and loaded. They want to walk out, one-stop shop, one appointment. Where do you balance immediate load for cosmetic concerns and real world, will this hurt the life expectancy of it?
I would say that when it comes to loading single tooth implants, and that's kind of where I live doing that all the time, and placing them immediately and loading them. The only reason to load, in my humble opinion, an immediate load in an implant for a single tooth is pretty much aesthetic purposes in the anterior zone, let's say. Posteriorly, I would do them once in a while for some patients that have really big smiles or they really want that tooth. But it's an immediate placement and immediate load of a single tooth restoration is an advanced procedure. And it's not something that specialists feel comfortable doing all the time even. So it's one of those things where you have to kind of walk before you run. And when you get to that point, you've placed some implants and you've restored them and provisionalized them already, you've gone through that whole process, then you can start looking at doing those things and spending the time and effort doing that. Right, Sam?
Yeah, I mean, I couldn't agree more. I think the crux of the matter is we've got good scientific literature, with long-term data that supports some pretty defined protocol and criteria for when we are even able to consider immediate load. And, things like getting good initial primary stability on the implant when you place it to be able to load it at the time of surgery. These are things that, we teach in our courses because you're right. It's easy for that young dentist to get talked off the cliff and get thrown to the wolves, by the very person that wants them to do the procedure. And so really the clear defining differential in that is a knowledge base, a sound knowledge of when to do certain protocols and why to do them. And do you have a reasonable expectation that they will be successful? And so, it really comes down to education and being taught when, it's okay to do things like immediate load and when, no, it may be a little bit too risky for this particular situation.
I've noticed one thing that's been gaining popularity more and more and more is as a more atraumatic way to extract the teeth. I remember going to Cologne, Germany a decade ago, and the Germans were, selling different instruments, and, go around the periodontal ligament and loosen it up and all this kind of stuff. Do you think it's really starting to take off, or do you think dentists are still just going in there with a small elevator and forceps and traumatically extracting a tooth as opposed to atraumatically extracting a tooth?
I think that that's one part that we're seeing dentists do a better and better job in, as we see this more and more. And that's truthfully what our Core 3 program is. Atraumatic extraction is a large part of that course. We're really learning how to go about this and some simple tools and tricks so that they can really go about this in an atraumatic fashion. Because if you want to be able to do any kind of implant dentistry or any kind of really good dentistry, I think you have to be as atraumatic as possible in what you're doing. And an atraumatic extraction, it's getting better. There's a long way to go yet, but I think dentists in general are better than they were even 10 years ago.
And I think that lends itself to the fact also that, in everything we're doing in dentistry today, whether it's an extraction, whether it's a crown prep or a veneer prep or a implant, we've realized over the last, 10, 15 years that these concepts of minimally invasive dentistry and doing less can be beneficial is definitely a paradigm that pervades everything that we do. And I think that translates, especially with extraction, to, doing those extractions in the least traumatic way possible.
And also on extractions, there are a lot of people who do PRF, platelet-rich fibrin, techniques with it, and in the same medical dental building there's dentists who don't ever do it, and it's confusing to these kids because Sundeep, your dad's a dentist, right?
Yep, he's a prosthodontist.
He's a prosthodontist, so it's obviously some type of genetic disease, and you should not have any children, only adopt. But it seems like when you go into any dental school around the world, especially in Brazil and India, and you say, raise your hand if there's a dentist in your family, at least a fourth of the hands go up. I was
100%.
in one family's in São Paulo, Brazil, where this one family tree had 35 dentists in it.
Wow.
And you probably never heard of the guy I was talking to, Kevin Coachman.
Christian
Coachman. I mean, yeah. It's like, and then I was in New Delhi, and this dentist had this house, and it was connected to all these. Anyway, there was like 12 or 15 dentists in his family tree living there. So it's very confusing when you want to be a dentist, just like your dad, just like your mom, and you go there and, like, say you're a prosthodontist and your mom doesn't even own an articulator. And you hear about these techniques like PRF, and your mom says, that's crazy stuff. That's crazy talk. So what do? Your dad's a prosthodontist, so you've probably had differences in protocol opinion with him before.
Sure.
So how do you handle that?
Well, I think, look, I think when it comes to this dialogue, I honestly, Howard, it really comes down to differentiating between what I'd like to call with my dad, principle and protocol. So there are going to be certain principles, certain reasons, the why of what we do, whether it's, the material we choose to use for a crown, or, what materials we're using at the time of surgery, that we know the principles, we know what principles work. We've had those principles in dentistry for 20, 30, 40 years. But when it comes to protocol, meaning how do we actually execute on that principle, that's where things change. And it's really important, especially in my own personal experience with my own father, I was really blessed that he was open-minded enough to say, listen, I think that we should be doing it this way because of the principle, but I can recognize that with technology, with the advent of better science, better materials, better engineering, better software, there might be a better protocol we can follow to get to the same goal. And I think that's really where the difference is, especially when it comes to embracing these newer concepts. Not saying, well, that's just all hogwash because I've been doing it for 30 years and my way works, but more saying, listen, my way works because we're following these principles. And if you use this new innovation, you're following the same principles. You're just taking a little bit of a different path.
Okay,
And,
Bobby, you guys are both prosthodontists, correct?
Absolutely.
Okay, her mom doesn't own an articulator and says you don't need one. Continue that conversation with mom.
You know what? I remember sitting through my cross-board exams and having Carl Driscoll and Jonathan Waynes just kind of take me through articulators from like 1900 all the way through and having to memorize and learn everything. I'll tell you that, having an in-house lab with technicians and else, do we use an articulator? Yes, every day. Do we use an articulator like I used it when I was in residency? Absolutely not. We don't. And the reason why is because everything is so digitized in our office now. We're using everything in terms of articulation, in terms of digitizing our models. Everything we're designing, everything we're doing is actually on a screen. My lab is a fraction the size of what a lab would have been even 10 years ago, because it's mostly just computer screens and mills and printers. And so it's one of those things where doing the articulators, I think we definitely do for lots of cases still. But I think that we're getting more and more digital where the softwares are able to go about it. The new Trios 4 will be able to provide articulation and motion of occlusion in your iOS scan. Like we're going really, really far technologically that I think we can, we'll get to places that I think will be amazing in the future. But I don't think we're ready to give up the articulator altogether yet. But I think we're going down that road, truthfully. Now, maybe Dr. Rawal won't like that too much, but that's what I think.
Well, I'll be honest with you. I totally agree. I do a lot of my cases today through a fully digital workflow where I'm using the best articulator in the world, which is the mouth, and a virtual representation of it. I'm not even using an analog medium to replicate the mouth on some sort of machine on a benchtop anymore. So I totally agree with you, Bobby. I think what it really harkens to, Howard, to your point and your question is, if the mom was saying, I don't use an articulator and I don't need it and I still get great results, I think the question isn't, well, is the articulator needed or not? I think the question is, well, why do I want to use the articulator? If it's something new and something that I think is innovative and it really allows me to accomplish the same goals or the same principles through a different protocol, but that protocol now takes me half the time instead of not using an articulator and doing it in 30 visits. While I use an articulator, I'm doing it in 10. Or where we are today with using analog protocols and maybe doing a restoration in 10 visits. Well, now digitally we can do it in 2. Yeah. I think that really is the question you have to ask yourself. Is that new concept or is that new piece of equipment or is that new technology, is it allowing me to accomplish my goals in a better way, a more efficient way, a more practical way, or at least a less costly way, right? Which translates to more affordability for our patients. If you can check those boxes with that new concept or innovation, then yeah, I think you should try and embrace it in your practice. If you can't check those boxes, if it's something where it doesn't offer those benefits, then maybe you have to take a step back and say, hey, is it really necessary?
How close are we to virtual articulators and virtual Facebook transfers in prosthodontics?
Oh, I think, yeah, we're close. I would tell you that for a lot of things, we're there. I mean, Bobby can agree. In Bobby's lab, as he was alluding to, for a lot of restorations, they will be totally digital, modelless. They will only work in the digital world based off of a totally virtual articulator. And you have to remember, from a standpoint of logic, an articulator is our best guess of what's happening in the mouth.
And what is your go-to virtual articulator?
I would say it depends on the software we're using. A lot of times we're using 3Shape to help articulate and help with a lot of the motion that we have. And it all depends on the modules you have in the laboratory software for that. We use that tremendously, and that's pretty much our go-to. A little bit of dental wings here and there, but in general, I think 3Shape is our number one product for all of that together, for sure.
But 3Shape has a lot of different articulators that you can pick in their software, right?
Yeah. So we said in our practice, we said average values. I mean, look, we base a lot of things on some, again, sound fundamental principles. Back to my point a little earlier, the principles don't change, right? If we're going to design an occlusion on an analog articulator, and we know that we can set that articulator to certain averages to accomplish the goals that we are trying to achieve, we follow those same principles, but just in the digital world, where we set averages based on the same principles that we've had in dentistry for the last 20, 30 years. And that could be different for me than it is to Bobby, but whatever he believes in his philosophy, he can replicate that in the digital world. And I can do the same in my digital world. And then based off of that, we can, design and create the restorations as needed. Now, that's going a step further because, as Bobby alluded to, we are now able to capture dynamic records in the virtual world, meaning we can see how a patient's own mandible moves with relation to their maxilla and replicate that in the virtual world to create a truly custom, fully adjustable articulator, which is the patient's mouth.
Okay, I'm gonna hold your feet to the fire though. You're saying sound principles stay the same, but protocols change. Okay, and
sure.
She graduated. She's with her mom. And she's in this town where I live in. And her mom says, look, I've placed thousands of implants and I've never done this PRF thing, one thing. Voodoo, you don't need it. What would you say specifically regards to PRF?
So I'll take that just because we've been using PRF in our office for every surgery for the last 5 years. And everything before that I did without it. It's not that you can't get the results without it. It's just like everything else. It's not like you can't bond using old bonding agents and old composites or composite. It's not like you couldn't use amalgam. You can use old products or different ways of doing things, right? Like today, people are doing socket shield and other things as well. It's not that we couldn't do things previously. Is it getting improved? Do we get improvement? And I'll tell you that with PRF, we do see clinical results both in soft tissue and in hard tissue. There's results now in humans showing that we're going to get an accelerated bone healing in certain aspects, especially integration. When it comes to the infection rate, one of the best articles published in oral surgery just recently was that a decrease in post-operative infection rate and third molar extractions. And that's massive. So it's not that you cannot get the results without it. It's just that you may get less complications with it, and you might get overall just a better result. The standard of what you're doing will increase and hopefully stay at that higher level over time. That's the ability in your results.
Okay, now I'm going to ask you a question, and you're going to think it's dumb, and you're going to think I'm stupid. But this is Dentistry Uncensored. I keep it real. I get a lot of emails, howard@dentaltown.com, and I know these guys. But the bottom line is this. If you point out anybody in the United States who has placed over 5,000 implants today, okay, they're old.
Yep.
And they did them all on what type of radiograph?
They're a radiograph,
a Pano.
2D image.
So I have friends who are with their dad, and their dad's saying, I've placed 5,000 more implants than your teacher. And I did every one of them with a 2D Pano.
Yeah.
What do you say to Dad?
Sure.
No, I'll tell you, this one is the one I love talking about. And I'll tell you what. We only hear this argument in dentistry. And the reason why is in dentistry, every single person in their practice is the king or queen of their village, of their hut, of their castle. And they've done it their way for however long, which is their protocol. And they never compared what they do and how they do it and what they're doing with the next person. There's no standardization across the industry. And so when someone in dentistry, it's only one where you say, we've been doing it for this long, or I've done it this way for so many years, and it's worked for me, so that's what I'm going to do. And when we look at the hierarchy evidence, that's probably the worst evidence out there because it worked in your two hands, but is it going to work in someone else's two hands? So when someone says I placed 5,000 implants, and use a 2D image, I placed the first 1,000 implants pretty much I placed with a 2D image. I use a CBCT every case now. Why? Because it's better. I can plan better. I have the longevity. What I'm going to do is better. I'm able to do things overall better. Is the result better over time? I would say yes, because you're going to get less complications long term, and we understand things better. It's just a matter of now when we build a house, we don't do what we did 20, 30 years ago. We get 3D renderings and we get other images to do that. And the reason why is because we can plan better.
Yeah, and I would take it. I would also take it a step further. And when I talk about this very subject, I mean, Howard, the answer to me isn't, well, you've done it with 5,000 implants with a 2-dimensional radiograph, and therefore you don't need 3-dimensional CBCT. Because if you look at it from that very linear black and white, do I need it or not, you're missing the big picture. Because the big picture today is it's not about the CBCT and looking at things in 3 dimensions. It's about the CBCT, looking at it in 3 dimensions, and then, as Bobby alluded to, using that data, putting it into planning software, creating a guide, or going into robotics, or creating the definitive restoration and then delivering that at the time of surgery. You have other applications because of the technology. So it's not so much, do I need a CBCT to place implants if I've placed 5,000 implants before? No. But if I want to be able to offer a better experience to the patient, do it with less time, have less potential complications, have better outcomes, and be able to do more in one visit or be more efficient, then I need to start embracing some of the newer innovations that are out there.
Okay, I have another question. A lot of people are starting to say that the need for a sinus lift is going away quickly because as implants get shorter and fatter, it used to be all the implants were the same, and you had to have a really long implant, preferably one that goes all the way out the back of your head, around the moon a couple times, and comes back with a bolt on it. But with a really short, and I want to be the poster child to support anything that's short and fat. So I want to get behind this. But are short, fat implants going to replace a big bulk of sinus grafts and sinus lifts?
I think so, absolutely. My master's thesis was on short implants. I would say the indirect sinus graft, the sinus bump, where most practitioners have 5 to maybe 7 to 8 millimeters of bone. It's really hard to justify putting in something that goes into the sinus and does a bump by putting in one study that was published in Germany that I was a part of with the data acquisition. They looked at bicortical fixation of an implant without a sinus bump versus indirect versus short implant, and there was no difference in the results over time. So I think when it comes to indirect sinus graft, and when it comes to doing bicortical fixation or having a short implant, I think we're going to see less and less of that over time. I think the direct sinus graft will always be around because in those cases, you have nothing to put the implant into. You have to graft. But when it comes to those bump procedures, we do less of them now and still load because the amount of bone you have below the sinus that engages the implant that's made it is directly correlated to the results that you have long term. And that's so a short implant that's fat has a surface area that's better than something that's skinny and long.
I want to address something else. One of the things that's really stressing out a lot of people is they go back to their mom and dad. Their mom and dad saying, let's do these implants. It's all great and groovy. And she's just seeing a ton of peri-implantitis. And it seems like when someone needs to have their tooth pulled and get an implant, they're usually not the yoga instructor. They're usually not the vegan. Usually, I'm in Phoenix. They're beer drinking, cigarette smoking. I know Florida is the highest class part of America. So you might, actually they call Arizona the Florida of the West. So that shows you how crazy. You're in Florida and I'm in the Florida of the West. And a lot of the people that come in, the young kids are like, well, you're not supposed to put them in smokers. Well, why all my patients lose their teeth because they're a smoker? You're not supposed to. Every reason you're not supposed to do an implant is why they're in your office getting their tooth pulled. You know what I mean? So, so what do you do when the person that comes in is a smoking, drinking Irishman with a pack of Marlboro in his pocket, and then the one you put in 5 years ago has peri-implantitis? How do you juggle all this?
So What I would tell you, and I'll let, Bobby being our resident PerioPros dual boarded guy jump in here. What I would tell you is that, you bring up a very good point in terms of maintaining the health of implants versus just having implants being stable in bone. And that's something that we have not talked about in dentistry over the last 20 years. There's this big concept or big discussion and dialogue in dentistry about success versus survival. And just because an implant is, solid in bone doesn't mean that it's successful if there's, some peri-implant, issues around it. I will say that, this is a really interesting topic of discussion because, peri-implantitis is something that has been the big, elephant in the room for a long time. We don't have any clear consensus of how to define it. Is it peri-implant inflammation, peri-implant mucositis, peri-implant infection, peri-implant bone loss? And then we don't have really any good consensus on how to treat it and what the prevalence of it is in the industry or in the marketplace. And so it's really one of these areas that we need further discussion. We need further science to tell us what are good protocols to follow to help mitigate those kinds of issues. Bobby?
I think that how, just like you said, all the people that need implants are the people that we learn about saying, well, if you got periodontal disease, you have a higher bone loss. If you get smoking, you have twice as many failures, yada, yada, yada. We have friends all over the world that think it's bad in Arizona or Florida. In Mexico, a good friend, he said he didn't place implants on smokers, he didn't place implants. So it's one of those things where it's mitigating risk versus benefit. Maybe in the smoke, you're not immune coating. Maybe in the smoke, you're not immediately temporizing. Maybe in the smoker, you're taking a conservative approach and placing an implant and waiting a little bit longer to heal it. Going about things and then also informing your patient. You got to let them know and say, listen, this is something that you're doing that is now going to affect the long-term results of what we do. And, maintenance and everything else that's part of it is fine. But, there's only so much you can control as a practitioner. There's only so much you can do. And you're there to provide a service, and you're going to do that. Whether it's a smoker or someone who's got periodontal disease or whatever have you, you put them on a periodontal regimen, or they're going to get to go through initial therapy and go through all of the treatment, great. If they're not, well, then their implant is at risk. And I think they need to know that.
Well, if I couldn't treat beer drinking, chain smoking hillbillies, I couldn't work on any family members. So, we have to, we have to do that. I can't believe an hour has gone by and we're already over an hour. But is there anything? The problem with peri-implantitis is there's no pain. The patient loves the implant. They can go to McDonald's and chow down on any hamburger, French fry. They love it. But she's sitting there, and there's 5-6 millimeters of bleedy hamburger gums around this thing, and then she's reading about all the oral health, issues of peri-implantitis. So what do you do? What's the protocol when patient loves it, but it's peri-implantitis?
Yeah, you have to inform the patient. In our office, in our office now, we've got almost 25 years of implants placed that we've been maintaining, and we're having to deal with the multiple practitioners that are part of the office. And we deal with it every week. And we discuss with patients, say, listen, the implants has lost bone, and if we don't do something about it, the continued loss of bone will mean we lose the implant. And always the thing is, they say, I don't feel any pain. I don't feel anything. And we have to inform them, to show them. We take a scan, we show them that, we show them an intraoral photo. We need to inform and educate the patient to let them know what is the reason. Remember, they need to understand that an implant's not a tooth. There's not a nerve that's going to help them understand, or a ligament around that's going to help them understand or feel any pain or problems. And that's why also our recall schedule is 3 to 4 months, because for hygiene, and no more than 6 months is for that same reason. Is so that if something does happen, we catch it early. Otherwise, it's a silent disease.
And I also think it's important. We've kind of had this false notion in implant dentistry over the last 10, 15 years that implants are almost infallible. If they integrate early on, they're golden and nothing can ever happen to them. They're going to last the rest of your life. And that's not really true. I think we need to respect the fact that we're implanting a medical device in the human body, and it is the most complex implantable device we have in all of medicine, because it's the only implantable device that has to live inside the body and outside the body at the same time. And so we need to respect the fact that, it is not a perfect science and things can happen. And that's why it's so imperative that we are very proactive about educating patients, about selecting the right patient, about making sure we're maintaining them in the appropriate ways.
So do you have a Yomi now? Are you using Yomi?
So I do have Yomi. We've actually had Yomi for a little over a year now. It is it's a system we adopted. We were very blessed that the company Neosis is based out of Florida, and so we got in early on in the entire process. And so we've been doing robotics now with implantology for a little over a year, and really, we're excited about Yomi and the possibilities of robotics in dentistry. I mean, obviously, currently we're using it in implantology to create osteotomies for implants, but the applications are really limitless. I mean, we have the ability to do things like, bone reduction protocols. We have the ability to do things like orthodontics, eventually even get into restorative and operative dentistry. And manufacturing, whether it's chairside milling of restorations. There's a ton of secondary, tertiary, and so on applications with robotics that we're really excited about. It's eliminating the last frontier of inaccuracy in our operations, which is the human hand.
Well, I'm just waiting till Neosis comes out with a robot assisted wife. I'm waiting to remarry when it's a robot. Do you know how much further along that will be?
My sources tell me that that won't get FDA clearance for a little while longer.
I bet you never is going to come to Canada. That's never coming to Canada.
My only advice, we're 10 minutes over, is, I really liked what the Pankey Institute did. They, on Dentaltown CE, they realized it was a big gap to go from, I heard about the Pankey, to go spend a week there. And you guys got these 3-day courses. So what Pankey did is they made a 1-hour online CE course that summed up that week. And it really was a great marketing effect because it kind of bridged the gap between, I'm trying to help these kids make a decision. And flying off to go see you for 3 full days, I'm doing this. I'm trying to get, because I know if they could hear you, they would fall in love with you. I loved your Dentaltown course, but you might consider, you've already done an online C course with Andonis. I think you should do a 1-hour course to explain your 3-day core courses so they can meet the instructor, so they can start, getting in the mode. I think it'll be, I think it would help them to pull the trigger and go see you guys. I love everything.
Well, Howard, you must be psychic, because that was one of the things that we were going to discuss with you. We actually think that that's an excellent idea, and we're actually planning on creating those 1-hour kind of introductory videos that we could utilize on Dentaltown to be able to promote, like you say, that transition from hearing about us to seeing what that specific course is to actually attending the course. Yeah. Absolutely.
It just I want to help them pull the trigger. You know what I mean? And I want to push them. The dentistry is all you work with your hands, doing live surgery in an operatory. And if you're afraid of doing surgery on a live patient in an operatory, I'm not going to listen to, you're going to go be a bleaching, bonding, Smiles Direct Club oral scanner. I mean, no, you're going to get back on your horse. You got scared. You got bucked off. I remember when I got bucked off my first horse. You can't make this up. I was only 10. The horse's name was Lightning. That you probably should have known at 10. Don't get on the horse named Lightning. And it bucked me off onto an electrical fence in Fort Scott, Kansas. And I'll never forget, his mom, Judy Huff, said, no, Howie, you're going to get back on right now. You're not, because the longer you get off and think about everything that went wrong, then you're going to be afraid of riding a horse the rest of your life. So dentistry is surgery. It's blood and guts. It's all done in an operatory. Oral surgeons make the most money. Periodontists next. Your chain smoking alcoholic, good old boy Irishman who lives in Arizona while his cousin lives in Florida, I'm sure. They're going to come in. They're not ideal patients, but they're good people. And this is what we do. This is why we're dentists. And I applaud you guys for teaching. I applaud everything you do. And it was an honor for me to be able to podcast interview both of you guys today.
Appreciate it.
Hey, thank you so much, Howard. It's our pleasure.
And you tell that little girl, that adorable little girl that came in, is she going to end up being a dentist just like Dad?
If she wants it.
Does she have the gene?
Something in the water here in Florida.
All right. Well, maybe you should do 23andMe, you and your dad, just to give them more data.
There'll be too much acrylic in that report.
All right. Well, hey, thanks guys for all you do. Thanks so much for coming on the show today.
Hey, thanks a lot, Howard.